Hi, I'm Neal Kassell, chairman of the Focused Ultrasound Foundation. Gail's ISTU webinar on the history of focused ultrasound is by far the best piece to date on the subject. We have worked with her to edit a version that can be distributed widely to the focused ultrasound community and beyond. Anyone who has an interest in focused ultrasound must watch this. It is incredibly good.
So it is my distinct pleasure to welcome Gail ter Haar to another ISTU On-Air webinar series. So she received a highly coveted Oxonian education and, as you heard, was a founding member of the International Society of Therapeutic Ultrasound, and she served as its first president from 2001 to 2006. She's a passionate educator. She has supervised 28 PhDs with another 5 students still in progress. She's also supervised 4 MDs and 8 master's degrees. So she has directed a research team at the Institute of Cancer Research in Sutton for over 30 years. And the Institute of Cancer Research is a public research institute, and it's a constituent college of University of London in the UK. She is under high demand as an invited speaker. She has provided over 20 invited plenary lectures, as well as 200 invited lectures. We're very fortunate to welcome her today. She is the deputy editor of Ultrasound in Medicine and Biology, and she has certainly given me wise counsel over many years for my own career, for which I'm very thankful. She has published 229 peer-reviewed manuscripts and has an H index of 54 according to Scopus. She's edited 6 books, written an astounding 34 book chapters, and quite frankly, her honors are too numerous for me to list here without taking a significant chunk out of her talk time. So just to give you in a little bit of, if you don't know her personal, she is a real tennis fanatic and a doting grandma of 5. And I'm really looking forward to hearing her historical perspective on focused therapy ultrasound.
Thank you very much, Christy. As Christy said, I'm going to talk to you today about the history of Haifu. I'm going to start with a disclaimer. I'm not going to talk about, in any detail about the following, because when I started looking at this, I thought, well, I could talk for 5 or 6 hours on the history of Haifu, and nobody wants to listen to me for that long. So I've narrowed it down to some, I think, key points. I'm not going to talk in any detail about the history of prostate Haifu or uterine fibroids, of interstitial devices or cardiac devices, or intraoperative devices. Much as I'd like to, I'm not going to talk about the history of immune stimulation using ultrasound or histotripsy oral combination treatments. And the other disclaimer I want to make is I'm a physicist, so this is a physicist's view of the history of ultrasound, of Haifu, not a clinician's view. I rather like this cartoon. I don't think it's a real choice, rhyme or reason. I think there's a lot of reason. In poetry, there's a lot of rhyme and artistry in physics. My very first postdoctoral position was, and it's the one actually in the institute I'm still at, I was invited by Professor Kit Hill, one of our Frye awardees, to join him. And he developed this thing called an infusogram. Basically, somebody has a new idea, which looks promising, and everybody takes it up and thinks it's the best thing since sliced bread. And that's a very English expression. I hope it's also one that other English speakers understand. But sliced bread was a real invention and aid to people in the kitchen. Then there's a time when people think, well, it's not all it's cracked up to be, until somebody rediscovers the literature and thinks, well, maybe it wasn't as daft as we first thought. There's new technology, maybe we can use it. And it does have its uses. If it's used appropriately, then it begins to take off. We can do that with Haifu, very much so, I think. In the early 1950s, there were brain studies, and we're going to hear about those. And then people start to say, well, what can we use these high-intensity focused beams for, other than the brain work? But then it seemed to look good, but maybe other techniques might be easier. For example, if you're going to do things in the eye, maybe it's easier to use a laser. If you want to try and treat Parkinson's disease, doing brain exposures, maybe it's better to use L-DOPA. So it dies away again. But then people realize, they get back into the literature. I mean, I was one of these people who looked back at the literature and think, well, maybe we could look at this again. Radiology has caught up with us, so we can image, we can target much better. So ultrasound and MR, we're getting more and more in these early years of Haifu, mid years of Haifu, I should say, we're getting more and more sophisticated, and there's a possibility of us using it. And then there's a recognition that actually Haifu does have its uses, and this is sort of where we are now, and somewhere on this. I hope it's not a downward curve. Maybe for ablation it is, and maybe it's coming up for other things, you know, histotripsy and drug enhancement. But you know, let's look at it. I rather like this quote from George Bernard Shaw: "Science never solves a problem without creating 10 more." I think those of us in research know that that's absolutely true, and thank goodness it is, else we wouldn't have a career. So I showed you the enthusiograph, but maybe a more realistic timeline is shown by the number of publications per year. And I went into Google Scholar and looked year by year in the early years, and then through to 2020. And you can see that there are some publications in the early years, but we have this huge increase, really since 2000, in publications about Haifu. So this isn't all therapy ultrasound, this is Haifu in particular. And if you look in those early years and look on a larger scale, you see that there was this peak that I talked about, this early peak in the enthusiogram, and then it begins to take off again. So it's been around for a long time, but it hasn't been used for all the time that it's been around. If we let us do a broad overview, and we go from the 1930s through to the 2010s, you see the different times at which various things have appeared. And this is what I'm going to talk about today, one way and another. As I said, there are some things I'm not going to talk about. So I'm not going to talk about drug delivery, for example. I'm not going to talk about sonothrombolysis, thrombolysis, but I'll talk about many of the other things. The first report of bioeffects of ultrasound was in 1927. And when I say that, that science and physics can be as beautiful as poetry, I would urge anyone who has never looked at this paper to look at it. It is beautifully written. It was published in 1927 by Professor Wood and Mr. Loomis, and it talks very nicely about Professor Wood encouraging Mr. Loomis to put his hand into an ultrasound field, and he felt it hurt. But I particularly like this part of the paper, and this is an example of the way in which it's written. So talking about putting small animals into an ultrasound field. So mice are less sensitive, a 20-minute exposure not resulting in death, probably a good thing. And though at the end of the treatment, the animal was barely able to move, the recovery was fairly rapid. Don't think we'd be able to get that past our ethics committees now. Goes on to say, the biologists inform us, however, that the blood count of a mouse is affected by fear, the corpuscles, the red blood cells, hiding in the liver until the danger is over. I think it's just beautiful writing. We don't write like that now. So Haifu, its beginnings were definitely in studies in the brain. Broadly, the early attempts to create lesions in the brain were largely unsuccessful. They got scalp damage and skin burns, and they found that it was important, it was necessary to remove a skull bone flap in order to get into the brain. Oops, the first report on tissue ablation that I can find was in 1942, this paper by Lin and Zomer and Chick and Miller, who were at Columbia University. They had a focused transducer, and it's a very nice diagram of it here. They worked at 840 kilohertz. What I particularly like about this paper is that they tried to calibrate. And the way in which they calibrated was by putting the transducer in an oil bath and firing upwards, and then looking at the height of the cone. So they say that the height of the cone proper is a reliable but crude indicator of the ultrasound output. So a lot of the paper is the effects are described in terms of the height of that of the fountain that they get when they fire upwards in oil. So it's a bit difficult to translate into watts per square centimeter, but at least they tried. There are some pictures of liver ablation. So here you can see a lesion in liver, and this is ex vivo liver, and there's you can just about see, I think, the boundary between lesioned and unlesioned liver there. They went on to look at irradiating the brain of living animals. They say that it was very hard to produce focal changes in the brain without simultaneous injury to the surface tissues. In all 5 animals that they did, 3 cats and 2 dogs, they showed more or less severe injury to the scalp in the area of application, while only those 2 animals who were exposed to radiations of maximum intensity showed any signs of local cerebral effects. So they had to use their maximum intensities that are available in order to get anything in the brain itself. I particularly liked their future ideas. I mean, it could be a grant that we're writing today. They say that the application of treatment at maximum output intensity for a minimum period of time was necessary to produce the focal changes. That makes a lot of sense, doesn't it? You're not going to get too much surface heating. And they suggest the use of a mosaic of 4 to 6 2-inch curved crystals. So an array, and we're all using those now. Their conclusions here: in animals, focused ultrasound of high intensity produced local cerebral changes as inferred from behavior disabilities and as demonstrated as autopsy. This local brain effect was achieved through intervening scalp, skull, and meninges. The resulting behavior disabilities, so obviously got effects, disappeared from 2 to 16 hours. They say that it's important that they need to improve the generation and application of the focused ultrasound beam as suggested, whereby it would be possible to increase still further the focal effects in the brain, the corresponding decrease or elimination of complicating surface injury. So they knew that they could get changes in the brain, and they knew what they wanted to do to make it better. A later paper, this is 2 years later in 44, they did that. They lifted a skull flap, and here you can see a cross section of the motor and premotor cortical area in a monkey, and this is in a cat. It's 2 days after 15 minutes of transcranial application at maximum intensity. It's a long exposure. It's not surprising they got a lot of damage. And then, as we all know, the Frye brothers got into the act. So they were based in Indianapolis in the United States. So Bill Frye and his brother Frank Frye. Some of you may have met Frank Frye. He was around in the early days of ISTU, and he was our very first recipient of a Pioneer Award, which we then went on to call the Frye Award. They used a 4-transducer system, 4 transducers with plano-concave lenses on the front, but aligned so that they were confocal. They produced high intensity at a focal spot. They described that in this paper in 1960, but they also described it earlier on. I'm sorry about that. You can see here, you can see here the photograph of the, I can't stop it. You can see here the transducer that they used as a photograph, and here there's a cross section of the transducer itself. They suggested that they wanted to go on to use a reflector focusing irradiator to use a single head, irradiating head. If you look in the literature, you can find the patent that they filed, both for the transducer and for the coupling device. So this is a coupling device. You can see it's a bowl with a hole in the bottom to allow the sound through, and this contains the coupling medium. And you can see that here. So this is their system. Here's their 4 confocal transducers. The animal, here you can see a rabbit underneath here, and you can see their coupling device. Now we think quite often we worry about the fact our systems are quite large. and that we would like to have smaller, transportable, portable systems. Theirs was super large. It was actually in 2 rooms. So I don't know how well you can see this. I've taken it from the only paper I could find, but you can see here in the top room, it goes through the ceiling into the bottom room where the animals were. So here's the animal, and you can see the transducer coming down through the ceiling with all the electronics in the top room. The carriage unit for supporting moving the irradiators was in the room above. And here you can see a human head holder, not very well, I'm afraid, but the way in which when they were doing human treatments, they had some ear bars that held the head in place. But actually, they were able to make lesions just as well as we can now. Here you can see a small lesion in the white matter of a brain of a cat. And here you can see another lesion. It goes slightly into the gray matter, but you can see it very clearly. So they could make lesions as well as we can. Obviously, targeting was much more difficult for them because they didn't have the sophistication of imaging techniques that we have. And Naren Sangvi sent me this. They were able to make lesions of configurable size and shapes, and this is in cat brain, and you can see some nice rectangular lesions here. They worked with Heimberger to do some human exposures. So here you can see, again, in the humans, they had to create a skull window. Here's the ultrasound transducer. There's a tumor that they were targeting in the brain. This is their coupling in this case. This is the sort of image they were trying to work with. I often think it looks like a polar bear in the snow. These early ultrasound images are really hard to interpret, but you can just about see the thermocouple that they inserted into the brain. It wouldn't be right to talk about the early days of Haifu in the brain without talking about Professor Lilly at MIT. He didn't do human treatments, but he did a lot of work in engineering work. He was also known as Pad Lilly, and he did a lot of work sort of really trying to quantify the ultrasound intensity and to do the basic physics and engineering of ultrasound treatments, of focused ultrasound treatments in the brain. So here's his system for creating what he called trackless focal lesions in the brain of a cat. And one of the things that I think was very nice about this particular paper, which he published in '62, was that he tried to look at the accuracy with which lesions could be placed. A lot of this paper is about calibration, and that's really worth reading. He was a meticulous scientist. So he looked at the accuracy of lesion placement. He found that it was different regions of the brain were different. It was easier to be accurate in different regions of the brain. So the maxillary division of the trigeminal nerve, he could place lesions with 100% accuracy, but when he got to the fornix and the mammillary body, it was much less easy to be accurate. Ballantyne and colleagues were working at MGH, Massachusetts General Hospital, and they were working with this system. It's called the Cosman machine. They were also doing human treatments in the brain. I particularly like this because when I first did my PhD many years ago at Guy's Hospital, we had a milling machine that was our method of moving the transducer, the ultrasound transducer. And John Pond was doing some work with Mary Dyson there, and it was looking at histology, and he used a milling machine to create large areas of lesions. At around the same time, Petter Lindstrom, a Swedish neurosurgeon who coincidentally was married to Ingrid Bergman at the time, was working to see whether he could use ultrasound to perform lobotomies. He wanted to avoid the excessive trauma that was currently experienced in lobotomy operations. He thought that using ultrasound, he could cause minimal damage and produce reasonably controlled lesions in the brain. He used a plain quartz transducer and started working with rabbits. He found that he was getting quite a lot of damage away from the area that he wanted to destroy. So he invoked some very simple focusing techniques in order to get localized damage. The paper, which was published in 1954, describes, first of all, using a cup with a slight cone shape containing the contact medium, but then he went on to use a cup with more of a cone shape to produce a better focusing effect. And that seemed to be effective. Here you can see an image from the paper of a dog brain. On the right-hand side of the brain, he exposed through the intact dura, and on the left-hand side, he turned the dura back, and using exactly the same exposure conditions, he showed that essentially he was showing the absorption of the dura. He was getting a bigger lesion if he didn't have to go through the dura. He went on to try this in humans. He realized he had to remove part of the skull, so he removed 2 buttons of bone, as he described them, here in the front of the skull. This is his transducer with his plastic cup holding the Ringer's solution that was the coupling agent. He treated 20 patients for carcinomatosis and cancer-related pain. In his paper, he reports 8 case histories. He says the procedure was relatively simple, carrying minimal risk, and he got pretty good results, he felt. A satisfactory lobotomy effect was obtained, in most cases in spite of the fact that the tissue alterations were minimal. He thought he could control the damage, and I like this expression that unintentional mutilation can be avoided. Here you can see a cross-section of the brain. He had post-mortem slices in some of his patients, and here you can see the lesion that was produced. At the same time, in Sweden, Lars Leksell was working. He was wanting to develop Haifu for treating psychiatric disorders, something that we're only coming back to now. They successfully produced a system for creating periventricular lesions. Here you can see Lars Leksell with his stereotactic frame. These are the 2 transducers that they developed between 1949 and 1950. The photos were sent to me by Lars's son, Danny. You can see the frame with the transducer, and this is the clinical system. But Leksell was frustrated by the need to have to produce a craniotomy and the poor imaging that you got with ultrasound. So instead, he turned to developing frame-based stereotactic radiosurgery, for which he really made his name. And of course, he was pivotal in inventing the gamma knife in 1967. So here we have the early work. So Heimberger in Indiana was treated patients with late-stage, deep-seated brain tumors using Haifu in the late 60s and early 70s. He was using this transducer. He had 2 transducers were aligned using the Cincinnati milling machine that you saw before. So if we look at the results of these early works in humans, the early trials, so the Frye brothers were treating Parkinson's disease, and they treated 50 patients, and they said that symptoms were eliminated, but it stopped there. There were no further reports and no further clinical trials reported. Valentine was treating painful subcutaneous neurometer. Again, he got complete pain relief in 7 patients, but again, no further reports. So these findings were promising, but not followed up, probably because of the problems of raising a skull flap and the limited imaging that was available at that time. And also for Parkinson's disease, the drug L-DOPA was arriving at the same time. And easier to give a drug than to open the skull and do a brain treatment. So it was thought, well, we must be able to get through the skull. We want to avoid having to make a window in the skull. And the idea was to use MRI and to use phased array transducers, use phase correction techniques. And there are two groups doing this. So Kaleva Hunanen in Boston started working on this, and he was working with Incytec. He published a paper on the clinical applications of focused ultrasound in the brain, showing his multi-element transducer, showing that he could get through the brain using phase correction techniques. At more or less the same time, at more or less the same time, in Paris, Michael Tonterre and Jean-François Aubry were looking at time reversal to do the same thing. So I'm not going to go into the physics of time reversal, but many of you know it. So you fire your ultrasound beam through the skull, you look to see how it's been distorted by the skull, you correct it, and then you fire the corrected beam back into the skull, and you get your focus back. So Jean-François has sent me some of these images. Here's their transducer. It's a random array. So Jean-François worked on his PhD on this. It's a semi-random array here, and this shows it working. So here you have the pressure plot with the uncorrected beam, but if you do your time reversal and correct the beam, you get your sharp focus back. So you can then go on to do treatments in the brain. And that's what we have now. We have a clinical device, an MR-guided system, the Exablate Neuro, which is, as you all know, is being used very successfully for the treatment of essential tremor and other things. So Kobe Vortman from Incytec has sent me these nice pictures. This was the early machine in 2005, but it's been developed over the years, and this is the current machine now. So this is really become one of the major uses of Haifu, and it's very exciting. And it's interesting and fitting that this is one of the first applications that was looked at in the 50s, and is now one of the most commonly used common applications of Haifu now. So we look back at the 1950s and 60s. What were they looking to treat? Well, Russell Myers was working at the University of Iowa Hospital, and he was working with the Frye brothers with their device. So they treated Parkinson's disease, they treated involuntary movements, both from cerebral palsy and what they called classified hyperkinetic disorders. They tried to treat intractable pain following cerebral vascular accidents. They treated phantom limb pain. They treated what they called hypersensitivity to stimulation of peripheral sense receptors and discomforting sensations. At the same time, Valentine was looking to give pain relief with those painful neurometer, and Heimberger was looking to treat cancer. So what are we doing now? Well, if you only have to go to the Focused Ultrasound Foundation website to look at the huge range of things that people are looking at of treating in the brain. So we've come a long way over those 70 years. The next application I want to talk about is the eye. And when you look at the literature of focused ultrasound, high intensity focused ultrasound in the eye, the names that come up the whole time are Jackson Coleman and Fred Litzy. Jackson Coleman was an ophthalmic surgeon working in Columbia. Fred Litzy was an engineer, I think, working at the Riverside Research Labs at New York. A wonderful example of engineers and clinicians working together. They developed a device called the Sonocare for treating glaucoma and retinal tears. It was a 4.2 megahertz device, 8 centimeter diameter, the 9 centimeter focal length, had a diagnostic ultrasound probe in its center, so very much similar to what we're using these days. Here you can see it. And they could demonstrate that Haifu had a role to play in treating glaucoma. In '82, there's a publication by Silverman that claimed that 79% of patients had a sustained lowered intraocular pressure at a year. That's the goal of treating the glaucoma. And they treated 880 patients with it. And they also used it to seal capsular tears in the eye. It was quite difficult to use. You only got a single pinpoint lesion at a time. You had to move the device between lesions. And of course, with the eye and with very poor imaging, that was quite difficult to do. So it was a complex and slow procedure and had side effects. But now we have something different. We have the company Take Care who've produced this device. I think it's the only application I know which has disposable transducers. It's a very clever little device. This is the treatment head. You see these 6 transducers that are, again, confocal. This fits into a little cup that fits over the eye. You can see it here. So it's first of all, this cup with coupling fluid is placed over the eye. They don't need to do any imaging because the eye, everybody's eyes, they're slightly different in size. So you have slightly different size cups, but it's always centered. So when you can see the pupil, you know that you're centered. Once you've got that in place, you just slot this treatment head in place and you can do your treatments. And the idea is that you treat several regions at once for the treatment of glaucoma. Very nice little, very clever device. I'm going to put this in because although there wasn't that much work done on it and it didn't last for long, there's an ear specialist, Jack Angel James, who was working in Bristol, and he was working with Professor Peter Wells, who was a very well-known ultrasound physicist and who was the first editor of UMB. And they were looking to see whether they could treat Meniere's disease. So Meniere's disease is a condition of the inner ear that makes you feel dizzy and gives you tinnitus, a very unpleasant disease. And they used Haifu to selectively irradiate the vestibular portion of the inner ear using a narrow beam of ultrasound waves to expose the bony labyrinth. And they found that this worked quite well. It was also being used by Arslan in the States. Not many publications on it, but it seems to have worked, and I'm not quite sure why it disappeared. So the next application I'm going to talk about is for cancer. Many of you will have heard of Nostradamus. He was a French philosopher, seer, I guess you would say, who worked in the 16th, who was around, he was around in the 16th century. And he wrote a number of predictions. And it's interesting that one of them, he said that sound waves would kill cancer between 1992 and 1998. He also predicted that Princess Diana would be killed in a car crash in Paris. Very clever man. I think the answer is you can read these runes and interpret them in any way you want. But I was given a book about Nostradamus, and I was very interested to see that this was one of the interpretations of his writings. The very first reference I can find to using ultrasound for the treatment of cancer was by the Hungarian Szent-Györgyi, I can't pronounce it, but so any Hungarians, I apologize, who published in Nature in 1933. He said in his letter to Nature that the effect of ultrasound radiation on Ehrlich's carcinoma had been studied by Goschi and was found to have no specific effect on the tumor. So it was a negative finding. Who knows what intensities they were using, but not very encouraging, but it was the first reference I can find for ultrasound in cancer. Fred Kremkow, who was at Wake Forest University, published a very nice early review on the use of ultrasound for cancer therapy. And I was fascinated by this. This is the number of papers and abstracts on cancer therapy published over 5-year periods between 33 and 77. And so this is the number of publications. And these different letters tell you which country they came from. So Germany was being very prolific in publishing about ultrasound in cancer. I guess he says the United Kingdom, I suppose that's meant to be England, but we were working in it a bit. The USA is A, so the Americans were working in it. So was Hungary and Japan and Russia. But in 1949, there was a Congress in Ultrasound in Medicine in Erlangen in Germany, where a lot of people presented papers. Not all the papers were, but some of them claimed very good success, others didn't. But the conference came out with what was called the Erlangen Resolution, which said ultrasound is not suitable for cancer therapy and its clinical use should be discontinued. That's a bit discouraging, isn't it? In 51, a chap called Pullman analyzed reports from the years up to 49. He found reports on 133 clinical cases. Only 17% showed an improvement. 76% things were unchanged, and 7% got worse. So you can see why the Erlangen resolution was made. But it was also pointed out that the excess of enthusiasm killed it. And that's your best thing since sliced bread part of your enthusiagram. But this wasn't Haifu. These were low intensities of ultrasound. The first real publications of Haifu in cancer, I think, come from Russia and from this amazing gentleman, Professor Burov. Burov was not only a scientist, he was also an architect. But he published work on the ultrasound treatment of malignant tumors. He described his high intensity sources. So he used unfocused beams, 1.5 megahertz, using 200 to 500 watts per square centimeter in pulse regime. You can see here his transducer. He did some beam mapping by melting, boiling plexiglass plate in water. This is his transducer. So he was exposing brown pierced tumor, which is a tumor that's transplanted in the rabbit testicle. He transplanted the tumor and then exposed them to ultrasound after 8 to 11 days, when the tumor was about 40 cubic centimeters. He used frequency of 1.5 megahertz, as I say, and this intensity range and exposures of 1 to 2 seconds. So the papers tell us, and I have to thank Vera because I can't read Russian, but in 40 to 80% of cases, the tumor resolved completely several months later. The resulting scar was often calcified, clearly pronounced immune response was observed. So one of the earliest reports of immune response as well. They did some work in humans as well. They did some clinical trials of melanoma treatments. They treated 10 patients, mainly in the terminal stage of melanoma. And in some of the cases, they saw that the melanoma disappeared completely. So it says at the bottom, in some cases, positive results were not obtained, and that several patients died of severe concomitant disease. That's what you would expect with a clinical trial. You only get to treat very sick patients for whom there is no other treatment. But they did see complete resorption of melanoma in some patients. We move on. If we move on to the 1990s, Guy Valenciennes in Paris modified a lithotripter to produce a device that's called a pyrotherm, and he was doing bladder treatments. He treated 20 patients with bladder tumors using, here we have an ultrasound probe, so this is ultrasound guided. He had a multi-element transducer working at 1 megahertz, intensities above 10,000 watts per square centimeter. We're using a range of pulse lengths in his experiments and his studies. But of 20 patients, 75% had normal urinary cytology at a month, and 67% had no recurrence at a year, which is really exciting for an early clinical trial. And he published his work in various places, for example, in this paper in urology. Now we know that we can destroy tissue very selectively with Haifu. If we turn the intensity up, we get instantaneous cell death. And if you're going to be able to do that, you have to be sure that you've placed your focus in the right place. So you need to be able to do very accurate treatment planning. You need to be able to locate your target very accurately. You need to be able to monitor your treatment, and you need to be able to follow it up. So you need very good imaging and targeting. So here we have the lethal gun sight, but you've got to target the right thing. And there are rival guidance techniques, as we all very well aware. So we can use ultrasound imaging or we can use MR imaging. They each have their advantages and their disadvantages. For ultrasound, the imaging and therapy beams travel in the same path. You can get very much real-time imaging and monitoring of tissues. You get a very high spatial resolution with ultrasound. The devices are compact, and you can put your imaging and therapy into one head. MR, on the other hand, gives you very clear anatomical imaging. You can even image through bone, which is good if you're going to do, for example, treatments in the brain. And you can do temperature mapping using the correct sequences. Ultrasound guidance relies on changes in echogenicity to tell you that you've actually produced the changes you want in tissue. So here we have, this was a large hepatocellular carcinoma, and I have to thank Feng Wu for this, for these images, and these were published by him in 2004. So this is the area to be treated on this slice. You paint out the region to be treated point by point, focal point by focal point, or focal volume by focal volume. You start at the back if you can, because you cause changes to the tissue with your heating, with your ablation. And as you work through this slice, and you can see these are consecutive slices, you paint them out until you see these hyper echoes. And if you look at the difference between this one, whoops, this one, this first one, and the last one, you can see that you've got the echogenicity, the bubbles that have been produced that show that you've done your ablation. So that's the way in which ultrasound guidance works. Magnetic resonance guidance relies on temperature mapping using proton resonance frequency shift sequences. And you can see here two of the displays from the two different MR guided systems that are commonly used. So using this PRFS sequence, you can temperature map, you can watch your treatment. This is one of our treatments from the Marsden using our sonar lead. This is a bone. You can see we heated the surface of the bone, trying to give pain relief, heated it very successfully here, and you've got your temperature scale here. You can also calculate the thermal dose, and this is from the X-Ablate system. Once you get to the required thermal dose of 240, you see that it changes color and you know you've done your treatment. So where are we with clinical studies? We did our first patient treatments at the Royal Marsden using a homemade device, very much a homemade device. You can see our single element focused bowl transducer here, homemade water bath, homemade system for translating the transducer. We had a cardiac ultrasound device that we swapped in and out to get our imaging. But we treated 75 phase 1, phase 2 patients, mostly with liver cancer. That was our first device. This is the Chongqing Haifu device, the ultrasound guided device. This was their system in 1999. This is just a system for moving the transducer. It's nothing more than that. The transducer sits under the bed, patient is in here. And the way in which the Haifu treatment works, as I showed you earlier, is that you start at the back of the tumor and you create your lesions from the back working forwards. The first treatment done in China using this device was to treat malignant bone tumors. You can see here osteosarcoma in a patient. This is pre-Haifu. The patient had some chemotherapy, and then she showed initial good response, but 36 months after Haifu treatment, and this was done in 1998, she showed complete response. Very nice result, early result from the Chongqing group. This device has been used in Oxford and as well as in China and a lot of other places now in Europe, but it's been used to treat metastatic colorectal carcinoma. You can see here a tumor that was treated, partially treated, pre-Haifu and post-Haifu, using this system. And this is a primary renal cell carcinoma. Again, you can see the treatment pre and post-Haifu. So nice that you've got absence of contrast uptake, showing that there's no blood supply to that region and tumor destruction. And this is one of a pancreatic cancer. Same story here. It was targeted. This is the cancer, the pancreatic cancer that was targeted, and this is the absence of contrast agent uptake afterwards, which shows the effect that was had by the Haifu. So that was ultrasound-guided Haifu. With MR-guided Haifu, there's lots of things I could have shown. I could have chosen to illustrate this, but I've chosen to show the work from Alessandro Napoli in Rome, published in 2013. Here, this lady had a bone metastasis. This is pre-Haifu, post-Haifu. You see, very successful using MR guidance. And MR guidance was very important here because you needed to be able to see into the bone. And here, this is a breast tumor that was treated here. So here's the tumor pre and post Haifu. So again, showing very nice anatomical images with the MR-guided Haifu. And osteoid osteoma, again from Alessandro. You can see here, again, it is very important to have MR for this because you can see the structure of the bone. Here's the tumor, and here you can see the effect. This is the nidus of the osteoma has been destroyed. And of course, MR-guided Haifu and ultrasound-guided Haifu is being used for uterine fibroids. This is one of the very early papers from Claire Tempany and Skaleva Hunen, and so 2003. See the positioning of the focal spots, and you can see the absence of contrast following treatment. So Nostradamus, back to Nostradamus. So he said that sound waves could kill cancer between 92 and 98. At the Institute, we did our first treatment in February 97. So he was pretty good at predicting the time that it was going to happen. And we didn't actually cure cancer. We were looking at proof of principle and doing partial treatments. So we know that Haifu will work in cancer. What are the clinical treatment systems that are available? Well, the very first purpose-built Haifu unit that we know of in the world was the one at Oxford. It was in an old Nissen hut. The unit was opened by Sir Peter Morris in 2002, and you can see here Professor David Cranston, Jibiao Wang from Chongqing Haifu, and this is Katrina. This is Peter Morris, Professor of Surgery at Oxford, and this is Katrina Leder from a very well-known soap opera in those days, Airline. And this was the system. This is the system set up in Oxford. So as I said, again, this is the system in Oxford. The ultrasound transducer sits in a water bath underneath the patient who lies on the bed here. And these are the pioneers of this Oxford unit. Here, this is James Kennedy, who really set the whole thing up in his PhD and did the first treatment. This is one of our first patients. It wouldn't be a history of Haifu if I didn't mention David Wilde. David Wilde was a businessman who heard about Haifu, heard about Chongqing group, and worked very hard to bring the Chinese system to the UK. And because he knew David Cranston, it went to Oxford, and the rest is history. So here we have Feng Wu, who's one of the pioneers, of the clinical pioneers of Haifu as well. And it was this unit that did work with a lot of liver treatments that enabled the Chongqing system to get a CE mark to allow them to treat liver. And that, of course, makes it much easier for everybody else to get CE marks and FDA approval and that sort of thing. So this is their current system, the Chongqing Haifu's current system, JC200. It looks a bit more sophisticated than the earlier device. So that was ultrasound guidance. If we look at MR guidance, the first company to really produce a system was Incytec with the Exablate. And you can see here Kobe Vortman, who's really instrumental in getting this going, with Frank Yolesh in Boston. And here you can see their current system, and that's their early system. So this slots into the bore of the magnet. They work mainly with GE magnets, although they're trying to, they have now systems that will work compatible with other magnets. And the other MR-guided system is the Sonaleave, now from Profile Medical, originally Philips, but bought by Profile Medical, which is one we have at the Royal Marsden Hospital in Sutton. And you can see here Thomas Andre, who helped us get it going with people from the Focused Ultrasound Foundation, and Nandita D'Souza, who's the clinician who helped us do all our clinical trials. I'm going to mention prostate briefly, but only in terms of technology. The most clinical experience to date with Haifu is in prostate, and most of it's done with ultrasound guidance, although MR guidance is also now available. The two companies that one knows of for prostate Haifu are EDAP Technomed, who produced the Ablatherm, now called the Focal One, and what was Focused Surgery and is now Sonacare, who produced the Sonablate. So Emmanuel Blanc and Jean-Yves Chapelon sent me this slide to show you how the Ablatherm has developed over the years. So the first prototype was developed in 1993-95 and used, and you can see it here. This had a therapy transducer, an imaging transducer, and the imaging transducer had to retract in order to do the therapy. Transrectal device, they're both transrectal devices. And you can see how the number of treatments has really risen over the years. So this is up to 2012, with 30,000 treatments. So this is the early Ablatherm, and this is the current, the Focal One. And you can see that it's just a more sophisticated version of really the same thing. What's really been developed is not only the transducer technology, but the imaging and the display, the user interface. Very young Jean-Yves Chapelon here and Emmanuel Blanc watching a treatment in the early days. The Sonablate system, and I'm grateful to Naren Sanghvi for these slides, it was used, again, very similar, a smaller device. See the images here, the ultrasound images here. It was first developed for treating benign prostate hyperplasia in 92, and it was used first for prostate carcinoma in 95. Professor Marburger in Vienna was really one of the pioneers, the clinical pioneers for using it for cancer. And here you can see Professor Marburger with Dr. Donahue doing their clinical studies with Sonablate. And this is the current system. So you can see that everything is much more sophisticated. It looks more professional, I guess you would say. But it's not that different, really. It's the imaging processing that's changed. I said there were the MR-guided systems. There are two systems. So there's the Tulsa system from Profile Medical, which you can see here. This is transurethral rather than transrectal. So you can see it here, and this is in clinical trial. And the Exablate prostate, which is, again, MR guided. This is a transrectal device. So where are we now? Well, the current status of Haifu is very different from what it was in the 1950s. I've taken this from Focused Ultrasound Foundation. See the total number of treatments. The most treatments, 40% of treatments, have been for uterine fibroids, which of course is something I've decided not to talk about very much. Prostate is here, and liver tumors is here, and the other things are in this segment. You can't read this, but you can see that just a wide range of things that Haifu is now being used for. And I'll just stop by thanking pioneers past, present, and future. These are just some of the photographs I found in my archives of people, starting from Bill Frye, Guy Valenciennes, right up to the present day. I particularly like this photo. These are the three first presidents of ISTU. So hear no evil, see no evil, say no evil, hear no evil. So Larry Crum, Kuleva, and myself. Thank you very much.